First of all, I would like to thank Jim for giving me the opportunity to present my experiences at this exciting meeting. In the next 20 minutes, I would like to discuss shortly our patient clinic for steroid users and the results of our prospective observational cohort study, the Haarlem study. I am an endocrinologist with a particular interest in male hypergonadism. In the beginning of my career, I saw some former steroid users with symptoms of hypergonadism. I realized that I knew very little about this particular subject, and I found it hard to find advice from colleagues both nationally and internationally. Also, solid scientific evidence to base management is scarce. For me, that was the reason to start the first Dutch outpatient clinic for steroid users. The aims of the clinic are to offer care for users or past users of anabolic steroids with health problems associated with the use of steroids, to do research and, based on our experiences, to educate the public and healthcare professionals. We are very clear about what we do not do. We do not prescribe androgens for cosmetic and performance enhancement, and we do not perform routine health checks in current users. Over the past 10 years, we've seen almost 400 patients from all over the country, mostly because of symptoms such as decreased libido, erectile dysfunction, fatigue, depressed mood, gynecomastia, and fertility issues. From these patients, we obtained a pretty accurate picture of who they are, what they are using, how they are using, and what problems they may have. We summarized these findings in a recent paper, and although the Dutch user is probably very similar to the one in your country, I will give you some highlights. Visitors of our clinic are male, mostly aged between 20 and 40, and engaged in weightlifting, bodybuilding, strongman competitions, or martial arts. A minority participates in competitions. In our clinic, only 1% of androgen abusers was female. More than 50% of users reported recent recreational drug use, such as ecstasy, amphetamines, cocaine, and cannabis. 1/3 of users have friends or relatives who are also using steroids. Almost half of steroid users consider themselves to be addicted to steroids, mainly due to the perceived positive effects on mind and body. The population seen in our outpatient clinic is selected on the basis of health problems and may not be representative for all steroid users in the Netherlands. Therefore, we started a 1-year observational cohort study in 100 androgen abusers without health problems, the Haarlem study. Men eligible for participation in the Haarlem study were at least 18 years old and intending to start a self-initiated cycle of anabolic steroids on short notice, that is, within 2 weeks after signing informed consent. The anabolic steroids had to be acquired through their usual channels. The scheduled cycle had to be at least 6 weeks long, comprise at least 2 different types of androgens, and average a weekly dose of 200 mg or more. An exclusion criterion was anabolic steroid use 3 months prior to informed consent. Men will also refuse to participate in the study if, within 6 months prior to inclusion, a new chronic or psychiatric illness had been diagnosed, treatment for chronic illness had been started or altered significantly. Subjects visited the clinic 4 times in 1 year, and a medical investigation was performed at baseline, that is, within 2 weeks before the start of anabolic steroids, in the last week of the steroid cycle, 3 months after ending the cycle, and 12 months after inclusion. When comparing the baseline characteristics of the Haarlem study cohort with our outpatient clinic patients, we found that both populations are very similar with respect to age at first use, type of exercise, recreational drug use, type of steroid use, and the way of use. This slide summarizes the type of anabolic steroids used in both cohorts. Note that most users used more than one type of steroids simultaneously. For the Haarlem study, we made a qualitative inventory of the products obtained by our 100 study participants. Only about 1/2 of analyzed samples contained the anabolic steroid as indicated on the label, and more often than not, the samples contained steroid types not indicated on the label. In 5% of products, no active ingredient was found whatsoever. We suspected that roughly 40% originated from Eastern Europe and Asia, whereas 60% appeared to be produced locally in illegal so-called underground laboratories. Anabolic steroids are mostly used in cycles with a duration between 6 and 18 weeks. The unproven rationale behind this strategy is to gain muscle mass and strength during a cycle, allowing the body to recover between cycles. In our cohort study, the mean weekly estimated androgen dose was almost 1,000 milligrams, ranging between 250 and 3,300 milligrams. The estimate does not accurately reflect the actual androgen exposure due to the fact that it is based on the declared and not the actual concentration of the abused products. Moreover, it combines oral and injectable products and different types of androgens. However, it gives an indication that the weekly dose varies enormously between users and that the mean dose is highly supraphysiologic. For comparison, a normal substitution dose of an injectable testosterone ester to treat male hypogonadism should not exceed 100 mg per week. A cycle of anabolic steroids is not expensive. In our Haarlem cohort, the mean cost per week was 30 euros, adding up to 400 euros per cycle. This means that cost is rarely a barrier to start using anabolic steroids. Although anabolic steroids are by far the most abused drugs, a variety of other performance and image-enhancing drugs are commonly used. These can be categorized as muscle builders, fat burners, pre-workout agents, and agents to prevent or treat side effects. Depending on the nature and dose of these agents, additional adverse health effects can be expected. Similar to androgens, most of these products are illegally obtained and their quality should be questioned. Moreover, scientific evidence supporting the claimed effects is mostly absent. All users of anabolic steroids, assuming a significant exposure, have side effects, although the majority of these side effects is mild and transient, and some go unnoticed by the user. During androgen exposure, a large proportion of subjects reported positive effects: increased muscle mass and strength, decreased fat mass, increased libido, improved energy, and concentration. As expected, all users experienced at least one negative effect during androgen exposure, such as testicular atrophy, fluid retention, acne, agitation, snoring, palpitation, and gynecomastia. However, these were mostly considered mild, anticipated, and transient. As a result, only 13% of the subjects stopped or altered the intended anabolic steroid cycle due to side effects. 53% of subjects reported loss of libido in the 3 months after the end of the cycle, which is not unexpected, knowing that androgen abuse results in suppression of endogenous testosterone production. Surprisingly, other symptoms that are frequently associated with this steroid dip, such as erectile dysfunction, mood swings, or depressed mood, were not reported more frequently compared to baseline. The type and frequency of desired effects and side effects during and after androgen exposure were similar to those recollected by experienced users from previous cycles. The fact that 80% of our cohort had past experience with anabolic steroids suggests that for most users, the benefits of androgen abuse clearly outweigh the side effects. It also indicates that users of anabolic steroids are well aware of the possible side effects of androgen abuse. Besides moderate weight gain, a small increase in blood pressure, acne, and gynecomastia, physical examination during or after androgen exposure was mostly unremarkable. Gynecomastia is a well-known side effect of androgen abuse and was frequently self-medicated with tamoxifen to prevent or treat it. Acne and gynecomastia were mild and reversible in most cases, although 7% of participants already had grade 1 or 2 gynecomastia at baseline. And previous anabolic steroid use was strongly associated with gynecomastia at baseline and the development of gynecomastia during androgen exposure. Only one subject developed severe gynecomastia which did not recover during follow-up. 4 subjects experienced a serious adverse event during the study period: heart failure, acute pancreatitis, exacerbation of ulcerative colitis, and suicidal ideation. Of these, only a dissociation between androgens and congestive heart failure and suicide have been reported previously. However, our study does not allow us to draw conclusions regarding causality between these events and androgen abuse. In our study, the use of androgens had several adverse cardiovascular effects: a relatively small but significant increase in systolic and diastolic blood pressure, a 20% increase in LDL cholesterol, and a 30% decrease in HDL cholesterol. Also, a rise in hematocrit and platelet count. All effects were reversible within 3 months after stopping anabolic steroids. Longer cycles were associated with a higher hematocrit. The use of oral androgens was associated with higher platelet counts and a more adverse lipid profile. Weekly dose of androgens, although highly variable between study subjects, was not associated with any of the variables. Androgens induced an increase in cardiac left ventricular mass, a reduction of left ventricular ejection fraction by 5%, and a higher left ventricular stiffness. When androgens were discontinued, after a median recovery time of 8 months, all cardiac parameters returned to their baseline values. Irrespective of androgen dose and duration of use, anabolic steroid exposure resulted in complete suppression of the hypothalamic pituitary gonadal axis, as demonstrated by undetectable LH and FSH concentrations in nearly all subjects. Furthermore, testicular volume declined during anabolic steroid use as spermatogenesis decreased, with 2/3 of subjects having oligo or azoospermia by the end of the cycle. Androgen cycle dose and duration did not have a significant impact on the degree of suppression of spermatogenesis. After 3 months of recovery, mean testosterone concentration had returned to baseline levels for the entire cohort. When the pre-exposure gonadal function was normal, there was an 89% chance of having a normal testosterone concentration after 3 months of recovery and a 100% chance at the end of follow-up. These data suggest that full recovery of endogenous testosterone production takes place for the vast majority of androgen abusers after 1 cycle of anabolic steroids, independent of cycle cumulative dose or duration, provided pre-exposure gonadal function is normal. However, 31 individuals had signs of a normal gonadal function at baseline. To be included in the study, subjects were not allowed to use androgens up to 3 months prior to inclusion, and based on the evidence presented above, such a high rate of gonadal dysfunction was not expected. Of this group, of the gonadal dysfunction group, 94% had used androgens in the past, indicating past abuse as a determinant of gonadal insufficiency. These subjects had a significantly higher cumulative past androgen exposure, having abused androgens twice as long in their lifetime compared to the group with normal baseline gonadal function. 9 subjects still had a low total testosterone at the end of follow-up, and it is uncertain whether endogenous testosterone production will eventually normalize in these men. We were unable to determine other risk factors to predict slow recovery of gonadal dysfunction compared to other subjects that had a similar history of androgen abuse but did recover during follow-up. The recovery of spermatogenesis took longer than the recovery of testosterone production. Mean sperm count was still significantly lower compared to baseline 3 months after the end of the cycle. In our study, the mean time to recovery of spermatogenesis to baseline values was 53 weeks, or slightly more than a year. Recovery was faster in a subgroup of subjects with normal gonadal function at baseline, with a calculated recovery time of 30 weeks. In our study, PCT or post-cycle therapy did not show any beneficial effects on the recovery of parameters 3 months after the cycle. Although the use of PCT is widely advocated among users of anabolic steroids, there is hardly any evidence to support its use. Furthermore, the use of HCG or Pragnil had no detectable effect on testicular size or spermatogenesis, whereas this would be expected based on clinical experience in the medical literature. Liver toxicity has been described mainly in association with the use of 17-alkylated oral androgens. Of our cohort, 67% reported the use of oral steroids. However, mean levels of bilirubin, alkaline phosphatase, and gamma-glutamyl transferase decreased instead of increased slightly but significantly during androgen exposure, returning to baseline within 3 months. In most subjects, a rise in the concentration of ALT, AST, and LDH occurred. Although this may suggest liver damage, we assume this to be the result of frequent heavy workouts, underlined by the steep rise in creatine kinase concentrations during androgen exposure in almost all subjects. Steroid abuse has been associated with manic or hypomanic behavior, irritability, aggression, and even psychosis, whereas androgen abstinence has been associated with depression and lack of energy. In our cohort, 1 subject stopped using androgens due to suicidal thoughts. In the other subjects, androgens did not induce relevant psychological disturbances based on the results of psychological questionnaires. Although a significant proportion of our subjects self-reported increased aggression and agitation during androgen exposure, the aggression questionnaire did not reveal an elevated physical aggression index. Mean scores on well-being and quality of life questionnaires did not change during androgen exposure, although a significant proportion of the participants self-reported improved concentration and energy during the androgen cycle. Most importantly, the recovery period after abuse was not associated with an increased prevalence of depressive symptoms. Moderate to severe body dysmorphic disorder, according to the BDD-Y-box questionnaire, was present in 32% of subjects at baseline. Scores remained unchanged during androgen abuse despite the increase in muscle size and strength. Remarkably, the scores improved towards the end of follow-up, even though muscle strength and muscle mass are rapidly lost after androgen exposure. Our data show that all users experience both positive and negative effects of steroid abuse. For most users, side effects are mild and transient and may even go unnoticed. The reported weekly or cumulative dose cannot be reliably used to predict the chance, the type, or the severity of side effects. Higher androgen exposure was not necessarily associated with a higher risk of self-reported side effects or side effects such as elevated blood pressure, disruption of lipid profiles, disruption of gonadal function, or the degree of aggression or depression. On the other hand, there does not appear to be a safe dose of androgens or a safe type of androgen that is associated with a lower risk of side effects. Serious side effects do occur, but are highly unpredictable. Long-term side effects are still largely unknown, but may include cardiovascular morbidity and permanent gonadal dysfunction. We are awaiting the results of the effects of androgens on blood coagulation parameters and the results of the 2-year follow-up of our cohort. We would like to stress that using anabolic steroids is impossible without side effects. We were unable to identify a safe or a safer type, dose, or way of use. Longer exposure to lower doses of androgens is potentially more detrimental than short exposure to higher doses, since the former is associated with a prolonged adverse cardiovascular risk profile. Also, we found additional evidence that a prolonged exposure to high-dose androgens may result in prolonged and perhaps permanent gonadal dysfunction. Thank you for your attention.